Good afternoon. This is late afternoon on Wednesday, March the 12th, 2025. The Insurance Committee meeting of the Tennessee House of Representatives of the 114th General Assembly is now in session. Madam Clerk, please open the roll. Members, kindly remember to log in. Takes a moment, okay. Is it Mr. Clerk or Madam Clerk? Mr. Clerk? Mr. Clerk who announces what takes the votes. Okay. Mr. Clerk, or is it Madam Clerk today? Mr. Clerk, kindly count the members present.
Mr. Chairman, there are 15 members present. You have a quorum.
Thank you. Members, do we have any personal orders? Don't see any, but if any of you want good stories, you can go back to the conference room and Hudson is there. Okay, that didn't fly well. We will proceed with our calendar today. We are going out of order to accommodate our esteemed colleague. The first item that we are going to take up is item 9, House Bill 0150 by Leader Gant. We have a motion and a second. Mr. Leader, I don't see an amendment on this bill, do we? Okay. So kindly, you're recognized on House Bill 0150.
Thank you, Chairman. I'll be brief. What this bill does, it requires the Division of TennCare to reimburse air-based ambulance services that provide a covered service to a TennCare recipient at a rate not less than 67.5% of the federal Medicare program's allowable charge for participating providers. And it's currently at 34% right now. So I move passage.
Thank you. We recognize the needs of inflation. Members, do we have any questions? Representative Hakeem, you're recognized.
All right. Thank you, Mr. Chairman. Chairman Gant, by increasing the amount that they receive, does that automatically increase every time? Was it TennCare make an increase?
Representative Gant.
Is that what?
I don't believe so. Okay. Says Tennessee code specifies a minimum rate for ground ambulance. This bill will put air ambulance in line with that rate, but it's just a TennCare increase is all this is.
Okay. Is there anyone here that might be able to answer? Oh, I'm sorry, Mr. Chairman.
You're recognized.
Anyone might be able to answer that question for us here? I didn't.
Restate your question again. I thought I just answered it.
Okay, you told me it would, I guess, be on par with TennCare, but what I'm asking is, does that rate increase, or the amount increase every time with TennCare? Does it continue to go up?
Well, it would be under my impression we'd have to do like we're doing here and pass legislation to request that.
Okay.
I think that's reasonable. Yes, there is no automatic increase built into it.
Mr. Chairman, could I ask that of the attorney?
I'm sorry, could you ask?
The attorney.
The attorney, legal services. Yes,
Okay.
we will go out of session. And Ms. Lovin, you recognize.
Levin Middleton Legal Services. So the rate has to be at least 67.5% of the federal Medicare program's allowable charge. So the increases or decreases are going to be based on whatever the allowable charge is under the federal Medicare program. So if that allowable charge goes up, then this would go up. But if it goes down, my understanding is that this is tied to that amount. For TennCare.
Yeah.
Very well. Do you have a follow-up question for legal?
Okay, everybody else knows more about it than I do. I'll just leave it alone. But I don't have clarity on it. Thank you, sir.
Chairman Spicky, you recognize.
For legal, Mr. Chairman.
Proceed.
So just to clarify, the rate is set by the federal government, and the 67.5% of that will fluctuate based off of what the federal government sets for the reimbursement. And then as it goes up and down, if they increase it, then our reimbursement will go up because it's just 67% of whatever the federal government says. Is that correct?
That is my understanding. As the bill is written, it requires that they provide reimbursement for these services at a rate not less than 67.5% of the federal Medicare program's allowable charge for participating providers.
Okay, Yusuf.
Any
Is that
other
okay now?
questions for legal? Well, thank you. I think we got some clarity. We will go back into session. Do we have any questions for our sponsor? Chairman Sparks, you're recognized.
Representative Gant, during subcommittee, I asked you to share your personal story. You almost lost your life in a car accident. What's that been, 2 years ago, a year and a half ago? I just wanted you to share how, this was critical air ambulance for you.
Leader Gant.
Thank you, Representative Sparks. Yeah, obviously, me standing here today was very crucial for this service being in play. And of course, I had private insurance, but this would be something that would affect a lot of Tennesseans that don't have the private insurance that I did. And so, but this was very crucial to me, and it is very crucial to anybody, regardless of what type of insurance they have. And so that's why you see me standing here before you today asking for more money to go towards this. And hopefully we can do that. I mean, this does have a fairly significant physical cost to it, which has always been a struggle for this. But I feel like this year we've got enough interest in it that we might be able to actually pass this out of finance. So
Yes, sir. We're glad you're with us, sir.
Well, thank you. We are grateful for your presence here. Members, any other questions? Seeing none, without objection, we are voting on House Bill 150. All those in favor, please push aye. Opposed, no. Mr. Clerk, please take the vote.
Mr. Chairman, you have 17 ayes, 0 nays.
Thank you. The bill moves on to Finance, Ways and Means.
Yeah.
Thank you.
thank you, Chairman of Committee.
We'll get back on our calendar. Item 1, House Bill 1304. We have a motion and a second. And Chairman Hill, you're recognized.
Thank you, Mr. Chairman. I've got an amendment 004645 that needs to be added to the bill.
We have a motion on second on amendment 004645. Is it? All those in favor of attaching this amendment to House Bill 1304, please say aye. Opposed? The amendment goes on the bill. Kindly explain the amended bill to us.
Thank you, Mr. Chairman. House Bill 1304 is an administration bill that really opens up quite a few sections of code associated with insurance. And it does quite a few things that are really intended to be updating and clarifying It eliminates some of the things that it does. It eliminates Mini Cobra, which is a program and a plan that really is no longer in use. It requires getting rid of leaded ink for reports. That's right, you heard me properly. And it allows for commercial insurance for farms, among other things. And that pending any questions, I'd seek passage.
Well, thank you, members. Do we have any questions for Chairman Hill? Seeing none, are we ready to vote? Without objection, we are voting on House Bill 1304. All those in favor, punch the green button, and those opposed, it's the red button. Mr. Clerk, please count the votes.
Mr. Chairman, you have 16 ayes, 0 nays.
Thank you. The bill moves on to calendar and rules. Item 2 on our calendar is House Bill 1318 by Representative Reeves. We have a motion and a second. I don't see an amendment on this, so kindly explain the bill to us. You are recognized.
Thank you, Mr. Chair. This is a simple bill related to TennCare. We've got a program called Access TN that was put into place prior to the Affordable Care Act. It's a high-risk pool, and we're simply extending the close of that program 5 years to 2030. And there are currently 36 participants in that pool. And so we're just trying to extend that out and still serve these folks.
Well, thank you. Members, any questions? Chairman Speaker, you're recognized.
Thank you, Mr. Chairman. Out of curiosity, is this your first bill before the committee?
Regretfully, yes.
It is. Well then, can you explain why the date was chosen?
Well,
You're
am I
recognized.
recognized? Okay, thank you. I'm just guessing, but 5 and 10 years seems to be good round numbers. But beyond that,
Thank you for that detailed explanation. We appreciate it.
Well, you have overwhelmed them. And I think they're shell-shocked and ready to vote. All those in favor, please vote aye, the green button, and those opposed, the red button. Mr. Clerk, please count the vote.
Mr. Chairman, you have 16 ayes, 0 nays.
Thank you. The bill moves on to calendar and rules.
thank you, Mr. Chair and committee.
You're welcome. Item number 4 is House Bill 0201 by Chairman Hicks. We have a motion and second, and we are waiting for you.
Thank you.
I don't see any amendments, so kindly tell us you're recognized on this bill.
And Mr. Chairman, just to make sure, what bill are you on? Just because I'll have two.
It's 0201.
Perfect. Thank you very much, Chairman, Committee. House Bill 201 increases the rates. We pay our ground-based ambulance services for non-emergency runs. Currently, ambulance services are paid at 67.5% of the Medicare rate for each TennCare non-emergency run. This bill, again, would just increase it to 100%.
Members, any questions? Chairman Spicky, you're recognized.
Thank you, Chairman. Chairman Hicks, I just want to let you know this is probably one of the best bills I've ever seen in 7 years of the General Assembly, and your wisdom is well appreciated here in the General Assembly, sir. And I'm not saying that because you're the finance chair also, so. Great bill, sir.
I guess
Still,
Representative Scarborough, you're recognized.
Thank you, Chairman.
let him talk.
And Chairman Sapicki, I'm glad you pointed that out. I thought as a freshman, it was impressive, but I thought it was just because I was a freshman. Hearing that makes me feel a lot better about it.
Okay.
Please keep it coming. I appreciate that.
Representative Love, you recognize.
Thank you, Mr. Chairman. And having served on finance with you, Mr. Chair, I would say also that this is by far one of the very best that I have seen in quite some time.
Chairman Hicks.
Mr. Chairman, I am going to come back to this committee in about 3 weeks, and I hope we have this same enthusiasm that,
Well, I think it'll stick as long as you're still the finance chair.
yeah, I got you.
Well, gentlemen, thank you. It's been very impressive. Are we ready to vote on House Bill 0201? All those in favor, please punch green, opposed red. Mr. Clerk, please count the vote.
Mr. Chairman, you have 16 ayes, 0 nays.
The bill moves on to Finance, Ways and Means. The next item, House Bill 1000 by Chairman Hicks. We have a motion and second and about the same degree of enthusiasm. Chairman Hicks, I see an amendment 3970.
That is correct, and it does make the bill, sir.
We have a motion and second to attach amendment 3970 to House Bill 1000. All those in favor quietly say aye. Aye. Opposed? The amendment goes on the bill. Chairman Hicks, kindly explain the amended bill to us.
All right, thank you, Chairman, members. This legislation authorizes TennCare to continue to assess hospitals and make charity care and directed payments for the current year, fiscal year 25 annual hospital assessment. During last year's session, legislation was passed to modernize the hospital assessment to provide critical resources to begin to address the significant financial challenges faced by the hospital industry in Tennessee. The new structure of the assessment requires federal approval by CMS, and which it currently is in process of doing that. The legislation passed last year was written anticipating all federal approvals would be received for payments and processes to occur. While Tennessee has received partial approval for the updated program, the Division of TennCare requires additional legislative authority to continue to assess hospitals and make directed payments through the hospital assessment. So the legislation provides the required authorization while TennCare and hospitals await full federal approval. Again, as amended, makes no additional appropriations and has a non-significant fiscal impact.
Members, any questions? Seeing none, without objection, we are voting on House Bill 1000. All those in favor, please push the green button, oppose the red button. Mr. Clerk, please count the votes.
Mr. Chairman, you have 16 ayes, 0 nays.
The bill goes on to calendar and rules. Thank you.
Thank you, Chairman and Committee.
Representative Mayberry, my apology to you. We skipped over you, and it's not because you're a freshman. This is House Bill 1319. We have a motion and a second. You're recognized on this bill. I don't see an amendment.
Thank you, Mr. Chairman. House Bill 1319 extends the repeal date of Tennessee's Children's Health Insurance Program Cover Kids from June 30th to June 2025 to June 30th, 2030 to continue to provide coverage for uninsured Tennessee children and pregnant women who are not eligible for healthcare services under Tennessee's Medicaid program. Like Medicaid, CHIP is jointly financed and administered by the federal and state government and covers about 40,000 individuals in Tennessee. I stand to answer questions.
Members, do we have any questions? I think they've run out of originality. Seeing no questions, we are ready to vote on House Bill 131. Okay, all 1319. All those in favor, please punch the green button, oppose the red button. Yeah. Mr. Clerk, please count the vote.
Mr. Chairman, you have 15 ayes, 0 nays.
Thank you. The bill goes on to calendar and rules. Congratulations.
Thank you, Chairman Committee.
Item 6 on our agenda is House Bill 1074 by Mr. Vip Garrett.
Thank you.
We have a motion and a second. I don't see any amendments. You're recognized.
Thank you, Mr. Chairman. I actually do have an amendment that I think is traveling with the bill, ending in 4013.
It is traveling with the bill.
That's right. That's right.
So,
Thank you. Thank you, Mr. Chairman. 2 or 3 years ago, I carried a piece of legislation that you all passed regarding prior authorizations for any kind of diagnostic testing. It kind of made it where communication between the provider and your insurance carrier had to talk to the patient. And a year or so after that, hopefully this bill made it better, where there was a prior auth legislation that made it the situation a whole lot better, which in turn made my piece of legislation that you all so graciously passed obsolete. So this bill removes it. That's all it does, Mr. Chairman. Gets rid of some legislation that is no longer needed.
well, thank you, members. It has been explained. Do you have any questions? Chairman Spicky.
Thank you, Mr. Chairman. So since we're removing this piece of legislation that you passed, do you owe the people of Tennessee any money back?
Representative Garrett, you're recognized.
Thank goodness this is not going through finance, so we won't have to have that conversation. So
All right. Any other questions? Well, thank you for the effort to save the state some money. We are ready to vote on House Bill 1074. All those in favor, you know the green button, and oppose the red button. Mr. Clerk, please count the votes.
Mr. Chairman, you have 15 ayes, 0 nays.
Thank you. The bill goes on to calendar and rules.
thank you, Mr. Chairman and committee.
Thank you. Item 7 on our agenda is House Bill 0171 by Chairman Reedy.
Thank you,
Mr. Chairman, we have a motion and a second, and you have an amendment.
Yes, Mr. Chairman, 3595.
Yes. Can I have a motion and a second to attach the amendment, please? We have those. All those in favor of attaching Amendment 3595 to House Bill 0171, please say aye. Aye. Opposed? The amendment goes on the bill. Chairman Reedy, please explain the amended bill to us.
Thank you, Mr. Chairman and committee. This is my annual pilgrimage to this committee in bringing a new date set for the ground ambulance assessment fee. And I can go much deeper than that if the freshman on the committee needs to know exactly what we're doing.
Okay. Members, do we have any questions? We have questions been called without objection. We are voting on House Bill 0171. All those in favor, the green button, oppose the red button. Mr. Clerk, please count the vote.
Mr. Chairman, you have 16 ayes, 0 nays.
Thank you. The bill goes on to Finance, Ways and Means. Thank you.
Chairman, committee.
Item 8 is House Bill 654 by Representative Hicks. Chairman Hicks, we have a motion and a second, and you have an amendment.
Motion.
4232.
4232, yes, Chairman, that's it.
Okay. We have a motion and second on the amendment. Members, all those in favor of attaching Amendment 4232 to House Bill 0654, please say aye. Opposed? The amendment goes on the bill. Chairman Hicks explained the amended bill to us.
Thank you, Mr. Chairman. This bill will provide incentives for physicians to build a psychiatric collaborative care model practice. This is a federally recognized, evidence-based, integrative behavioral health model led by a primary care physician who contracts with or employs a psychiatrist or psychiatric nurse practitioner as part of the care team. This bill would require commercial health insurers to cover and reimburse for mental health services provided through these modeled arrangements. I believe that by specifying in statute that there is insurance coverage for these type of care models, that it will give some assurance to primary care providers that the billing for services in these care models will be available for reimbursement. That will hopefully incentivize more primary care providers to build out those models. Thank you, Mr. Chairman.
Thank you. Members, do you have any questions? Representative Hakeem, you're recognized.
Thank you, Mr. Chairman. Chairman Hicks, just for clarity for me, are we saying that these persons would receive, I'm going to use the term, the normal rate, or is there a rate set for them that's different from people who are already receiving a rate?
Chairman Hicks.
Thank you, Mr. Chairman. This bill really doesn't cover a rate, but I'm sure that whenever they collaborate and whenever the physicians or the team, hires somebody to collaborate with, it is sort of a set rate on what those people will charge and what those people will make through the insurance. Yes. I mean, it's a set coverage for that.
All right. Thank you, sir.
Mm-hmm.
Members, any other questions? I think considering the relative shortage of psychiatry, this collaborative model will be very helpful. And it seems that most of the psychiatric care is given by primary care physicians also, and this will add to their support and expertise. Not seeing any other questions, we are voting on House Bill 0654. All those in favor, please punch green. Opposed, punch red. Mr. Clerk, please take the vote.
Mr. Chairman, you have 17 ayes, 0 nays.
The bill moves on to calendar and rules. Thank you.
Thank you, Chairman. Thank you, committee.
Item 9, we have already covered. So item 10 is House Bill 1045 by Representative Shaw. We have a motion and a second. And Representative Shaw, I don't see an amendment, so kindly explain your bill to us.
Thank you, Mr. Chairman. I really wished I could say that this was Chairman Hicks' bill, but I can't say that.
Okay.
This is pretty simple bill. It comes to us from Senator Wally and myself from some of our constituents, just to clarify that the net amount payable under life insurance policy or annuity contracts, that is for the benefit of the owners, which is a spouse, children, or dependent relatives, is exempt from all claims of creditors, including execution, attachment, seizures, and garnishments. It's just a simple bill, and it just strengthens the language that's already in the law. With that explanation, I stand to answer any questions you may have.
Well, thank you. Members, do we have any questions or concerns? Don't think so, and the question's been called. All those in, so we are voting on House Bill 1045. All those in favor, the green button, oppose the red button. Mr. Clerk, please count the votes.
Mr. Chairman, you have 17 ayes, 0 nays.
Thank you. The bill moves on to calendar and rules. Thank you,
Mr. Chairman.
Representative Shaw.
Members. Thank you.
Item number 11 is House Bill 0169 by Chair Lady Helton Haynes. We have a motion and a second. You're recognized, and we do have an amendment.
Yes, Chairman, it is amendment number 3958.
Yes, that's what we have. We have a motion and a second on the amendment. And all those in favor of attaching amendment 3958 to House Bill 0169, please say aye. Opposed? The amendment goes on the bill. Chair Lady, explain the amended bill to us.
Thank you, Mr. Chairman. This bill enables Tennessee women to obtain a 12-month refill of birth control from a pharmacy if their doctor prescribes a 12-month supply prescription. And this is only if a plan provides coverage for contraceptives. A prescribing healthcare provider may also instruct that a smaller supply be provided. Thank you, Mr. Chairman. And with that, I stand for questions.
Chairman Spicker, you're recognized.
Thank you, Mr. Chairman. Just a quick question. I've spoken to you about this already. Can you explain how it would work? Is, let's say a refill is issued in January for 12 months, and in July, that individual would lose the rest of the year's contraceptives. Could you explain how that would work?
Chair Lady.
Thank you, Mr. Chairman. Yes, if they lost part of the supply, the doctor could refill for the rest of the year, but the cost would be up to the patient to pay for that.
Thank you very much.
That seems fair. Any other questions? Seeing none, we have, Representative Hakeem, you're recognized.
Thank you, Mr. Chairman. Chairman Hilton Haynes, I understood if they're lost, but if their prescription is changed, we'll say after 6 months, would they have to pay for them, or would that be covered?
Chair Lady.
Thank you, Mr. Chairman. Representative Hakeem, it is only on a refill. So they would have to be taking this prior, and this would be on a subsequent refill that they could get the year's supply.
Okay. All right. Thank you, Mr. Chairman. Madam.
Any other questions? Seeing none, we are voting on House Bill 0169. All those in favor, green button, opposed, red button. Mr. Clerk, please count the vote.
Mr. Chairman, you have 16 ayes, 0 nays.
Thank you. The bill moves on to calendar and rules.
Thank you, Mr.
Item 12 is House Bill 0712 by Chairman Hale. We have a motion and a second. Chairman Hale, you recognize you have an amendment.
Yes, sir. 4672, or I'm sorry, 4627.
Yes, we have a motion and a second on the amendment. All those in favor of attaching amendment 4627 to House Bill 712, please say aye.
Aye.
Opposed? The amendment goes on the bill. Chairman Hale, kindly explain the amended bill to us.
House Bill 712 was brought to me by the Tennessee Disability Coalition. I'm sure that several of you have had visits. Today, matter of fact, had some members to sign on to the bill today after talking to some of the families. What this bill does, the goal of this bill is to provide a clear pathway for qualified family caregivers to be hired by home and community-based service provider networks in the state of Tennessee. Basically, it does two things. First of all, the bill asks TennCare and the Department of Disability and Aging to work together to develop a clear guideline processes for provider agencies to hire a family member. And then secondly, the bill standardizes access to ensure that family members are not disqualified based on family relation status, where they live, how the person given the care, what the program, what service programs they are enrolled in. And then the amendment removes conservators unless permitted by a conservator agreement. So with that, and if needed, we do have someone signed up to testify on behalf of the Disability Coalition if needed, Chairman.
Members, do you have any questions? Chairman Hill, do you think Mr. Strand needs to testify or only if we have questions?
I think that the bill kind of speaks for itself and the need and families. Like I said, a lot of us have heard from members of the disability community today. So if the committee would like to hear from Mr. Strand, then he's more than willing to come up and to testify.
Chairman Speaker?
Thank you, Mr. Chairman. I believe the explanation has been perfect, so I move previous question.
Okay. Question's been called. Without objection, we are voting on House Bill 0712. All those in favor, the green button; opposed, the red button. Mr. Clerk, please count the vote.
Mr. Chairman, you have 17 ayes, 0 nays.
Thank you. We do want to thank Mr. Strand for being available. Thank you. Next time, we will need your services. The bill moves on to Government Operations Committee.
Thank you.
Item number 13, House Bill 0195 is rolled by 1 week. Item 14, House Bill 0029. Chairman Spicky, you're recognized. We have a motion and a second. And I also see an amendment. We can verify the barcode.
Mr. Chairman, it's drafting code 004067.
We have a motion and second on attaching amendment 004067 to House Bill 0029. All those in favor, please say aye. Aye. Opposed? The amendment goes on the bill. Mr. Chairman, explain the amended bill to us.
Mr. Chairman, I would try to say I renew my motion because we passed this bill multiple years. And our Senate colleagues have been slow to react to this, but I'll give a brief explanation. What it does is it prohibits a health insurance entity from discriminating between a chiropractic physician and a medical physician with respect to the methodology used to calculate reimbursement or the amount of reimbursement to be paid for a service that is in the lawful scope of practice of a duly licensed chiropractic physician. It prohibits a health insurance entity from attempting to circumvent such prohibition by creating a chiropractic specific code or payment methodology not listed in the nationally recognized code book used by the health insurance entity for determining the amount of reimbursement. The bill is just bringing parity to all modalities. I'll be happy to answer questions, Mr. Chairman.
Members, you've heard the explanation. It's creating equality or parity in payment structure. Any questions?
Move previous question.
All right. Question's been called. We are voting on House Bill 0029. All those in favor, the green button, and oppose, the red button. I'm going to say this in my sleep.
Come on, Brock.
Mr. Clerk, please count the vote.
Come on, Brock.
Mr. Chairman, you have 16 ayes, 0 nays, 1 present not voting.
Well, thank you. Thank you. It's very fair of Representative Martin to not vote on this, although he does have a big smile. The bill moves on to Finance, Ways and Means. Item 15 is House Bill 0015 by Representative Love. We have a motion and second.
Mr. Chairman, if I could, in Finance, Ways and Means this morning, the Health Department testified about some things they're doing around sickle cell. And Chairman Hale and I talked about this, so I'm going to ask to roll this 1 week so I can find out if what they're doing through the Health Department may be able to provide the kind of support that I'm looking for these 306 persons that aren't covered by TennCare. So with that, I ask for a roll for 1 week, please.
Without objection, so ordered. Item 16, House Bill 0295. Do we have a motion? We have a second. The circumstances with this bill, Representative Love, kindly explain.
Yes, sir, Mr. Chairman. So I'm waiting on a report from the advisory committee, which I have been told will be out next week. And so with that, Mr. Chairman, I would like to roll this bill 1 week and wait for that report to come out.
Without objection, this bill is rolled by 1 week, awaiting for the DULA Advisory Committee report. Thank you. That finishes our calendar. You're recognized.
I do want, Mr. Chairman, to acknowledge we did have folks here to testify, but I want to let them know that we're working on the situation out and we could have conversation. That'd be plenty helpful. All right. Thank you.
Yes, we do want to thank Nakisha Faust, Rebecca Porter, and John D. Breedlove for coming. This is, hopefully we can do it next week. And we are ready for our presentation by RX Preferred. This has to do with PBMs. It is a complex and a favorite subject. Oh, okay. We will go out of session. Kindly remember that we have a little time, but also allow time for questions. And when the band is red, your mic is on. Do you plan to speak each of you at a time, or how do you plan to do this?
I'll go first and Mr. Hanson will go second.
Okay, kindly proceed.
Chairman, Vice Chair, Committee, thank you. We're honored to be here today. We are here on behalf of RX Preferred Benefits. We're headquartered right up the road in Mount Juliet. And I'm from Rutherford County, live there now, so it's good to see some of our representatives in the back. We are an independent, transparent PBM. And my name is Philip Dodd. I'm Vice President of Legal and Regulatory. I have with me Zach Hansen, Senior Director of Revenue Operations, and Dawn Holtz, Business Development Manager. So Chairman Kumar invited us here to essentially tell you what we mean by transparent PBM and how our model is an innovative approach to the traditional or legacy PBMs. So I know it's late on a Wednesday, so I'll turn it over to Mr. Hansen and we'll be happy to answer any questions after.
Okay.
Thank you, Mr. Chairman, committee members. Appreciate the time today. Like Philip said, we'll try to keep this brief but informative. So RX Preferred is a fully transparent PBM. We are in Nashville, been around since 2011, and we operate nationally with self-funded employers, state agencies, municipalities of all sizes. Work with some of the smaller employers, anywhere from 50 employees up into several tens of thousands, and larger. We have a plan with over 1 million members as a part of it. So we have a lot of experience in managing pharmacy benefit programs and have had a lot of success saving our plans significant amounts on their prescription drugs. At a high level, a pharmacy benefit manager is a company that manages the prescription benefit side of a self-funded or state-represented health plan. Their responsibilities include processing claims, managing a formulary or a covered drug list. They are also responsible for managing the pharmacy network, meaning which pharmacies can be used as a part of their plan. They also do clinical programs, cost containment strategies, and process for rebates on behalf of those plans. It's no secret that prescription drug costs are at an all-time high. There's been a lot of visibility on manufacturers for their responsibility in terms of high drug costs. And what we're here to talk with you about is that there is a traditional PBM model out there driven by the top 6 companies, and they are driving up healthcare costs with their conflicted models. As you can see here is a payer stock index from 2011 to 2021 that shows the difference between what the pharma stock looks like compared to what the payer stock or what the PBM stock would look like over that same time period. The model is one of vertical integration. So our market currently is created with an insurer that owns a PBM, that owns their own pharmacies, that is now starting to own their own provider networks. In those scenarios, each layer is paying themselves and controlling the patient. That means that one insurer has control over where they go to see their doctor, what drug they can get in terms of what drug is covered, where they can get that medication filled, and what the cost is. As Philip mentioned, we're a transparent PBM and an independent PBM, meaning we're not owned by an insurer as part of that. And we remove that conflict of interest as a part of our methodology. This is a look at the PBM profit sources for the large PBMs. They have a variety of ways that they make money and drive revenue at the expense of self-funded employers, state agencies, and individual members, including Tennesseans. A lot of the cost is driven in retention of rebates for branded medication, but also spread pricing. So spread pricing, to define it, is that PBM will pay a pharmacy one amount and they will bill the employer a higher amount and keep the difference. There's no visibility in terms of what they actually pay the pharmacy from an employer standpoint. So they could pay a pharmacy $10 for a drug and charge that employer $150 for that same medication. And that employer or state agency even would have no visibility on what the actual drug cost was. There was a second FTC report that recently came out that noted 6 key items. One is that the top 3 PBMs had significant price markups. They were dispensing the most profitable drugs out of their own pharmacies and steering towards them. They had over $7.3 billion in dispensing revenue, in excess of a national acquisition cost, and generated additional income via that spread pricing, which I explained. Specialty generic drugs. So some drugs will be classified as specialty. PBMs retain a list of specialty medications. Those large PBMs will dictate where those can be filled at and what the cost is. And then ultimately, this led to significant plan sponsor and patient drug spend. The market response is what you would expect. 80% of all prescriptions are processed by the top 3 companies, and yet 91% of all employers view their drug spend as unsustainable. And even more alarming, 3 in 10 are not taking their prescriptions as prescribed due to cost. So that's to set the stage for what the market looks like today. In terms of RX Preferred, we have developed what we call a zero conflict of interest strategy and a fully transparent model, meaning we show exactly what the pharmacies paid on behalf of an employer. We give them the data to validate that, and that also helps them make decisions on behalf of their members to find the best cost opportunity. We make no more money if the drug is higher cost as opposed to the other PBMs that do. Therefore, we are not incentivized at all to drive up healthcare costs or push back to a specific pharmacy. So we allow plans full visibility on their drug costs, and what we're focused on is that true drug cost. With this kind of visibility, members are able to shop for specific medications, look at other pharmacies, go online to price out medications. And our philosophy is that there's an open network, meaning they can go to any pharmacy, they can shop around, and we'll help them make decisions to drive down their drug costs, specifically with generic medication utilization. This is a look at that zero conflict of interest strategy that we model ourselves after. So it's everything is 100% pass through. There's no spread pricing. We don't own any pharmacies, meaning we don't pay ourselves, unlike the larger PBMs out there. And because we're not paying ourselves, we also allow plans to be able to customize their coverage however they want. So there's no incentive otherwise. We only charge a flat per paid claim fee for our services. And again, we view that as a zero conflict of interest approach. The PBM model is opaque and confusing. This is an example of how it can be. So the drug here is what's considered a specialty generic medication. The average wholesale price, as notated by a nationally recognized price source, is a little over $12,000. PBMs can dictate what's considered a brand and what's considered a generic medication. In this instance, one of the large PBMs said that this drug was considered a brand, and they notated it with a brand designation and gave a brand discount to the employer. That discount was 30%, so the employer paid $8,559 for this medication. This is actually a generic medication, again, by use of a public, a nationally recognized classification system. So it's a generic medication. The actual cost of the drug is around $3,000. Furthermore, we partner with Mark Cuban, Cost Plus Drug Company, and they have access to this medication for $355. So in a year on one medication, we're able to save this employer and the member $100,000. This is a look at a few high-cost medications and some lower drugs that have or lower costs available in the market. And these are all often life-saving medications. For reference, Gleevec is a medication for leukemia. Gilenya is for MS. Aubagio is for MS. And Humira is the top prescribed drug in the world and has several lower-cost alternatives available. And so when we work with employers, when we work with members, our incentive is to be able to get them the lowest possible cost so that they can afford their medication. We're what we consider a leading innovator in the PBM space. We're a founding member of a lobbying group called Transparency RX. We promote community and independent pharmacy. We want to keep money in the local community. It's part of our mission. It's part of our passion. We partner with Mark Cuban, Cost Plus Drug Company, work with multiple states on PBM education and reform, and actively lobby for transparency in the market. And the results speak for themselves. When plans switch to us from one of the large PBMs, they save anywhere between 20 and 50% on their drug spend in the first year. There are even instances where that number is significantly higher due to one medication that might be obscurely the price just charged a lot more than it actually costs. And really, this transparency allows us to be able to rebuild the trust in healthcare that's been lost. So if there's 4 takeaways from our discussion, one is that PBMs are overly complicated and can be simplified through transparency. If you administer a claim based on giving the data access and giving the consumer the information to make the best decision for themselves and for their family, drug costs will go down. Data is king. Ultimately, when we give claim level detail to our plans and to our members, they're able to make those smart decisions about how to afford their medication and what's available in the market. Most of the large PBMs will not provide that data and will really hide it from employers. Conflicts equal inefficiencies, where if a PBM owns a pharmacy and they're paying themselves, that is a conflict. That gives them the ability to create the price that they want to charge themselves, and furthermore, what they want to pay other competing pharmacies. And transparency is a catalyst for change. Our goal is to be able to really transform healthcare through this model, and we appreciate your time today.
Well, thank you. Members, do we have questions? Chairman Lafferty, you recognize.
Thank you, Mr. Chairman. Yeah, I'm curious with the way the drug companies and the pharmacies are all tied together. How is it that you guys are so good at beating them out on pricing? If they control all if they hold all the strings, how is it you guys are pulling this off?
So that's a great question. It's not necessarily, so a lot of times they'll think that volume equals better pricing. But we're finding is that it's not necessarily better pricing, it's that it's pass-through pricing. So if they pay a pharmacy a lesser amount because of their volume and they charge an employer a significantly higher amount, they're keeping that delta. That's where they're profiting, where we're just paying a pharmacy one amount, billing the employer that exact amount. And so that the pharmacy ultimately is getting a higher reimbursement from us, and the employer is getting charged less from us. So it's kind of a win-win situation, but it's not necessarily a pricing. It's about where they want to be able to charge, or what they want to be able to charge for the drug.
And since in many cases, since the manufacturer is also involved in this stream of drugs from the manufacturer to the distributor to the pharmacy to the customer. Are there concerns on your end that they will try and somehow squeeze you guys out, stop doing business with you, or?
Go ahead.
If I may. So the concerns that the pharmaceutical company is losing out on what we're doing, is that your question?
Maybe not so much that they're losing out as much as with the control that they have at so many different levels. Would they at some point go, we're not doing business with you guys. We're not going to sell you the drugs that you want to turn around and sell to your consumers?
Go ahead.
Thank you. That's a great question, Representative Lafferty. I think one of the things we see, and some of this is high profile lately, is that the large PBMs, we call them the big three colloquially, they are oftentimes at odds with the pharmaceutical companies. And so maybe a way to answer your question is we offer a different route for pharmaceutical companies to kind of get their product to more people without like the big three kind of determining what the boundaries of those deals look like, if that helps at all.
You recognize.
We also contract directly with employers and state agencies, and those groups don't want to lose out on those customers. So if a pharmacy chain, as an example, wants to be able to still service the covered lives that we have, then we really don't see them squeezing us out.
Thank you for your answers. Thank you for what you're doing. This is very interesting. Thank you. Thank you.
Well, thank you. Thank you. So you went over how the conventional PBM makes money. That is, they spread pricing, they bill certain amount to the insurer or payer, and sell the medication or pay the pharmacies a lower price. How about yourself? You said you have fixed pricing because the amount that is paid for the drug and the amount that is paid to those who dispense the drug is transparent. Okay. Kindly elaborate what is your part and how do you calculate that?
Yeah, thank you, Mr. Chairman. We charge a flat per claim admin fee for our services. We view it as a transaction fee, very similar to the way that a credit card would work. So from a PBM perspective, one of their responsibilities is to pay the pharmacy within the state laws and whatever that prompt pay law adheres to. And so when they pay the pharmacy, they act as almost as if they were a bank and then charge the employer back for whatever that cost is. And so that's when they're charging the spread. But it would be very similar to if anyone went to a store and your credit card dictated what the charge was and then what was actually reimbursed to that location. So we view it as almost a credit card transaction where we just charge a flat per paid claim and we disclose that to our clients.
And is there a fixed percentage?
It's a fixed dollar amount typically.
Dollar amount. Okay. So it's not based on the amount of transaction.
Correct. There's no, if it's a higher cost drug, if it's a lower cost drug, it's the same dollar amount every transaction.
Okay. And when it comes to, you mentioned Mark Cuban's pharmacy, I'm sure they purchase it directly from the pharmaceutical companies. They don't have a distributor between them and the pharmaceutical company. Is that correct?
Correct. They negotiate directly with manufacturers.
Right. And you could not do that.
Not for drug purchasing. We don't purchase drugs from manufacturers. We're processing claims on behalf of an employer that are buying drugs from a pharmacy.
Okay. Members, any other questions? Chairman Sparks, you recognize.
I appreciate y'all being here. You know, this is an issue that I think obviously is bipartisan. A lot of constituents reach out to all of us when it comes to high cost drugs. You know, what frustrates me is, you know, as someone that's a big fan of the free market, is when we see drug prices higher in America. What is it? 2 to 6 times higher than other well-developed countries. I mean, Great Britain, Japan, and others. Why is it? Why are the drug prices so high? I thought PBMs were kind of initiated to help lower drug prices and buy in bulk, that sort of thing. But it seems like it's had the opposite effect, especially among the 3 largest. You said dominate, what, 80% of the market share? Okay. Why are drug prices so much higher than other countries?
So I'll let Philip take this in just a moment, but I do want to point out that what you described was the original purpose of a PBM. It was built to lower drug prices. Initially, when PBMs first came into the market, they found that they were developing pharmacy networks, so which pharmacies could be used. And they said, well, if I'm doing this, I might as well negotiate a discount for my clients. Well, then they started saying, if I'm going to negotiate a discount, I want a percentage of that discount. Well, the way to make more money when you're negotiating based off of a discount is to raise the price. And so that's ultimately what led to the turn of how PBMs operated. And I'll let Philip talk through the point or the question that you had.
Yeah, that's a good point, Zach, and a great question, Representative Sparks, because this is what your constituents on the street will stop and ask about. This is what my family at the supper table, asks me about, and it's difficult. The answer is I don't know the answer, but that's the answer we get a lot. So I'd kind of like to try to get us closer and situate RX Preferred in that mix. And so as to healthcare costs between the United States and other countries, the United States, a big reason of it is, bottom line, we want more choice. We have more choice. We want more access. We have more access. And we have a higher quality in the United States. And so as to drugs, generally we develop all the drugs. Our universities do the research for all the drugs. We develop innovative ways to deliver drugs, and we, as the United States, consume more drugs for a host of reasons. And so the more precise question, I think, is why are drug costs so much higher in the United States than overseas? And so the high kind of profile arguments that we've seen recently, we have the big PBMs blaming the pharmaceutical manufacturers and pharma blaming the big PBMs. And it seems to me that they're both correct to a point. To an extent, there's some truth to both of them. And I think I don't want to make an overarching value judgment, but this is kind of the purpose of large publicly traded corporations, is they have to deliver year over year profit to their stockholders. It's not good or bad. This is American capitalism. And so these big PBMs and these big healthcare companies have gobbled up huge swaths of the marketplace. This is where we believe that RX Preferred kind of comes in. And so our approach to this misaligned model is essentially we offer the value that's very clear in a transparent fashion and without these conflicts of interest that come from vertical integration. So we like Zach just said, we don't own our pharmacies. We're not owned by health insurance companies. We don't have biosimilar manufacturing arms like a lot of these guys have now. So it's really taken a complex system and simplifying the PBM's portion of it.
Zach, the PBMs simply have too much control, and it's a captive market, so they control too much.
Well, explain the vertical integration again. Explain that.
Yeah. So, do you want to go back to this slide? Yeah, I'm happy to go back to the slide to talk through it real quick. So, in this instance, the insurers own the large PBMs. So if you took, as an example, you have a United Healthcare, you have a CVS Health that owns CVS Caremark, and United Healthcare that owns Optum. Those are both Fortune 10 companies. If you took their PBM away, just the PBM themselves would be a Fortune 10 company. And so when a PBM is owned by insurer, they're managing the medical benefit and then they're managing the pharmacy benefit. Those PBMs then own their own pharmacies and they're starting to own their own provider networks. So at that point, what you have is you have an issue because you have a patient that's controlled by the entity that owns the PBM at every stop. So that provider writes them a prescription for a drug. That PBM then dictates where they can get that drug filled, if it's covered or not, and then what they'll actually pay for that medication depending on where it's going to be. And so that vertical integration, what we're saying is that PBM needs to be independent. PBMs can't own pharmacies. PBMs can't be aligned with that insurer in terms of ownership structure because it just creates too much of a control vacuum.
Now, the FTC, I'm assuming, is looking at all this.
Yes, sir.
What advice would you give? I don't know how much control. It's a confusing topic. Most people are so confused about it. I like what Mark Cuban's doing, but is there any direction you could give us as lawmakers at what Tennessee can do to help this industry and not rely on Congress or anybody else to act?
Yeah, I think making independent PBMs more of a reality throughout the state is what it's gonna take. If the insurer owns the PBM and they have that much control, then a lot of times when they're talking to an employer, they might be willing to take a loss on their medical benefit because they're going to make so much money via their PBM. And so if you split out that that model and require transparency within the PBM, but also independence within the PBM, I think that makes everything a lot cleaner and there's a lot more of a level playing field.
Yes, sir. Thank you.
All right. Representative Hakeem, you're recognized.
Thank you, Mr. Chairman, and thank you all for being here. I want to compliment you. Based on what you've shared with me, I want to compliment you for what you're doing. I think it does help the clients, the average person on the street. And I guess you may have lost some friends in the pharmaceutical industry as a result of this. But what I want to ask you, is this an area, that spread that we're looking at, is this an area that the Protection Bureau? Financial Protection Bureau. I don't know if it's even still in existence now. It's still in existence with the new administration. But the point I'm trying to get at is that something that should have been looked at or can be looked at by an entity, a governmental entity like that? I think what you're doing will force some changes, but would it help the citizen to have that entity also be involved in that process? Consumer Financial Protection Bureau.
Mr. Chairman, thank you. Thank you, Representative Hakeem. Great question. The CFPB, I don't know if they're involved and to what extent they're involved. From what I've seen, the biggest thing coming through the courts as far as consumer protection has been with fiduciary liability on the behalf of large employers and large health plans.
Okay.
And so what this essentially says is that an employee can hold their employer, their health plan, to account for not going out to the market, finding, we would say, a transparent PBM, but taking a raw deal from one of these big PBMs and not really doing their due diligence and their obligation duty of prudence. And so that's a consumer protection kind of indirectly that's had some success recently. As to the CFPB, I don't know anything that hasn't come across my desk.
Okay. Thank you, Mr. Chairman, and thank you for what you're doing.
You're welcome. Given the current environment, CFPB is going to be significantly diminished as it appears. Chairman Martin, it's your turn, sir.
Thank you, Chairman, and thank you guys for this discussion. What's kind of the estimated number of people covered? Do you have that in your group, if you don't mind?
Yeah, a little over 2 million covered lives today.
Okay, covered. That's all I had.
All right.
Just seeing the number.
Well, thank you. Seeing no other questions, gentlemen, really thank you for being here. It's interesting, it's enlightening, and it's good to know that you're innovative and you have a different model. We wish you the best.
Thank you.
We will go back into the session, and seeing no other activity or questions, we stand adjourned.